Pediatric neurotrauma. This lecture covers both TBI and CCI. This lecture will review the epidemiology of pediatric neurotrauma, including statistics on incidence, risk factors, and age distribution. Neurotrauma is a leading cause of death and disability in children, with males typically having a higher incidence rate. Common causes include falls, motor vehicle accidents, sports injuries, and non-accidental trauma, child abuse. The mechanisms of injury can affect the brain, spinal cord, or both. Assessing TBI in children includes evaluating the level of consciousness using the Pediatric Glasgow Coma Scale, assessing for neurological deficits, and monitoring for signs of increased intracranial pressure, pupils. Imaging studies such as CT scans or MRIs are used when available. Spinal cord injury assessment involves checking for sensory and motor function reflexes and autonomic control. It's essential to determine the level and completeness of the injury. Initial treatment focuses on stabilizing the spine and reducing inflammation. Long-term treatment includes physical therapy and sometimes surgical interventions. The lead cause of trauma, mortality, and disability in pediatrics. The causes of TBI in infants include abuse and falls. In children under 4, motor vehicle collisions are added to the other courses in children over 4, and transportation including bicycle crashes are added. Delivery head injuries include intracranial hemorrhage, bleeding within the brain or between the brain and the skull, and cephalic hematoma, a collection of blood between the periosteum and skull bone, which birth trauma subgaleal hematoma often causes, a potentially dangerous swelling of blood between the skull and scalp layers that can occur after vacuum-assisted delivery. Infant traumatic head injuries can be unintentional falls, everyday activity, or intentional abuse of trauma through shaken baby syndrome as a result of the assault. TBI resulting from collisions or falls while riding bicycles or motorcycles, often exacerbated by not wearing helmets. The contact sports like football, rugby, and martial arts can lead to spinal injuries, such as gymnastics and diving also have a risk of cervical spine injury. Due to the potential for falls and impacts, non-contact sports can cause brain or spine injury. Recreational activities such as trampolining, skiing, snowboarding, and horseback riding carry risks of falls and collisions. High falls, such as from playground equipment or during climbing, can lead to significant spinal injuries. The ABCDs of trauma are also the priorities for pediatric TBI patients. The neurological assessment used the pediatric GCS. The pediatric GCS has the same range as the adult from 3 to 15. Eye-opening is not different from adult. Pediatric GCS is adapted for the verbal responses in the infant who does not yet speak. For example, instead of oriented speech, the baby babbles or follows the movement in its environment. Blood group. Determining the child's blood type is crucial if a blood transfusion is necessary during treatment. Skull X-ray. X-rays of the skull can reveal fractures of the skull bones, however. They are less commonly used because CT scans provide much more detailed information. CT scans involve radiation, so their use is carefully considered, especially in children. The Picarn algorithm, discussed in the next 2 slides, helps clinicians decide when a CT is necessary. MRI is often used when the immediate life-threatening issues have been addressed or when neurological symptoms are present that are not explained by the CT findings. The Picarn rule was developed to assist in decision-making for neuroimaging in children with head trauma. This flow chart is for children less than 2. If a child less than 2 has any positive response within the orange box, including a Glasgow Coma Scale of 14 or less, this indicates a severe injury, and a CT is recommended. If a child has none of the signs in the orange box, they are evaluated for signs in the pink box. If they have any of these signs, their intermediate risk observation is required, and a CT scan would be indicated on shared decision-making, like a physician's experience, and the history of severe mechanism of the injury, or if they have 2 of the signs. The prediction rule had a negative predictive value of 100% and sensitivity of 100%. 86.3, 100 for clinically significant traumatic brain injury in children. The PCARN rule was developed to assist in decision-making for neuroimaging in children with head trauma. This flow chart is for children less than 2. If a child is more than 2, has any positive response within the orange box, including a Glasgow Coma Scale of 14 or less, this indicates a CERV head injury, and a CT is recommended. If a child has no signs in the orange box, they are evaluated for signs in the pink box. If they have any of these signs, their intermediate risk observation is required, and a CT scan would be indicated on shared decision-making like a physician's experience and the history of severe mechanism of the injury, or if they have 2 of the signs. Cephalohematoma, the bleeding is gradual. Therefore, a cephalohematoma is typically not immediately evident at birth. Linear skull vault fractures, the most common types of fracture, do not require surgery. Non-surgical management includes closely monitoring the infant's neurological status, and regular follow-up appointments are crucial. The depressed area may gradually elevate and return to normal as the brain grows and the skull hardens. Surgical indications for depressed skull vault fractures include compound depressed skull fractures, signs of dural tear, neurologic deficit due to the pressure effect of the depressed skull fragment, persistent cosmetic defect after the swelling has subsided. The most common basal fracture in children is temporal bone fractures. Explain the different radiologic features. Relatively uncommon, approximately 1% to 3% of all pediatric patients evaluated for trauma are diagnosed with a spinal injury. Proper safety equipment such as helmets and pads is critical during sports and recreational activities to minimize the risk of spinal injuries. Additionally, when a spinal injury is suspected, it's important to transport the individual safely to avoid exacerbating the injury. Emergency medical services should roll the patient and immobile the spine until stability is assured. Conditions that increase risk of spine injury: Down syndrome, osteogenesis imperfecta, connective tissue disorders, mucopolysaccharidosis, Klippel-Feil syndrome, renal osteodystrophy, and prior history of spine surgery. Approximately 8% of children with impaired consciousness from a head injury will also have a cervical spine injury. Unexplained hypotension may be a sign of a spinal cord injury. Signs of spine injury: point tenderness are along the spinal column, torticollis, abdominal tenderness, and bruises over the flank. Anal tone and perianal sensation should be assessed gently, even in a small child. The presence of a rectal sensation may indicate an incomplete spinal cord injury, even when there is no lower extremity movement. Lying an infant supine on a rigid board causes the neck to flex. Therefore, young children must be secured on special pediatric boards with an occipital recess. If these are unavailable, the infant should have the torso elevated. X-ray, first line of imaging modality, are readily available and less costly. Perform AP and lateral X-rays. Lateral X-ray must include 7-tone junction. If the child over 8 years old does not have midline tenderness, altered level of consciousness, intoxication, neurological abnormalities, or other painful distracting injuries, there is no need for imaging of the cervical spine. Well,